Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. This is Open Mics with Dr. Stites. Imagine being diagnosed with one rare disease as a child, only to learn as an adult it is actually something different. At age 7, Alicia Smith was diagnosed with Hunter McDonald syndrome, which explained most of her symptoms. But as we know, science does evolve, leading to more clear answers. Alicia is joining us from home to help us share an important announcement which gives renewed hope to children and adults like Alicia, diagnosed with extremely rare diseases. Alicia, welcome. Also in the studio is Shobhana Gubendran, the genetic counselor and manager of genetic counseling here at the health system. Welcome in this morning. Delighted to have you. Dr. Jean-Baptiste Lepichon joins us virtually from Children's Mercy. Okay, now I know you go by JB. Did I come close in the correct pronunciation there? How close was I?
That was very good. Jean-Baptiste Lepichon, but you did very good.
Excellent. My French is so good. Not really. Dr. Lepichon, we'll say JB, is the Interim Division Director for Neurology. He's also a member of the FDA's Genetic Metabolic Disease Advisory Committee and serves as an advisor for several rare disease networks. We also stopped and talked with some of Alicia's doctors here before today's program. We're going to hear from them as well. It is estimated that 25 to 30 million Americans are living with a rare disease. You know, that's a lot. That's like almost like 1 in 10 or 1 in 11, huh? But what is considered rare? It's any disease affecting fewer than 200,000 people in the United States. Diagnosing rare diseases can take years and sometimes decades. That's a long wait before treatment can begin. Now we're excited to announce the University of Kansas Health System, Children's Mercy, and the University of Kansas Medical Center are designated sites in the NORD Rare Disease Center of Excellence, a national network advancing research, diagnosis, clinical care, data sharing, and access for rare disease families. Dr. Lepichon, what qualifies a health system to be a NORD Center of Excellence? And tell us, what does NORD stand for? And is this based on research structure, specialty clinics, patient outcome metrics? Talk to us about what it all means.
Pretty much all of the above. NORD is the national NORD is the National Association of Rare Diseases. And in order to meet the criteria, it's a very strict set of criteria that have been established. In order to meet the criteria to be a NORD certified center, the center needs to show the evidence of multidisciplinary coordinated care. That means that patient will be able to come and see all of the specialists that they need to see. And often with these rare genetic diseases, as Alicia can probably testify to, they need to see multiple doctors. So that's really important. You need also to show that the centers need to show that they have expertise in rare diseases. It seems pretty obvious, but it's something that you need to prove, and that is proven through publications, through the work you've done, through the infrastructure that you have set up. You need to be able to show that you have the research infrastructure and activity in order to support development of research and treatments for rare diseases. A key component to being to being certified by NORD is to show patient and family engagement. And I cannot emphasize how important this is. At Children's Mercy, we have 19 different PFACs, the patient and family council groups that give some recommendations on the various diseases. So, for example, for our Angelman Clinic, we have a PFAC that pretty much helps me run our entire clinic and decide the direction that we go. We have one that is entirely dedicated to rare diseases. You also have to show that you can provide education and training in rare diseases. And finally, and probably most importantly, you have to be able to show institutional commitment to the rare diseases. And that is really important because that institutional commitment is what supports both the clinical, the support for the clinical treatment of the patient with rare diseases and for research.
You know, I love that's a great description. And having been a cystic fibrosis doctor for many years, starting in '92, I've watched a population of patients who are rare disease go, up dramatically, and watch the life expectancy go up dramatically because of a lot of what you've just described as the infrastructure for cystic fibrosis is required to be a CF center, and the dedication of research so that patients were in clinical trials and doing things to help advance the search for a cure until, as in CF, we find new therapies that look like for about 90% of patients result in a normal life expectancy. So, I mean, it's just a dramatic story and probably the greatest story I've experienced on a personal level in medicine. Just one more comment. NORD is close to nerd, and I'm a nerd, and so I think it's great. I love that little acronym. Shabana, our genetics counselors do genetics testing in every single specialty we have in the health system. How has the role of genetics shifted to a now central diagnostic tool in rare disease?
Yeah, no, I'm very curious. I'm very eager for everybody to hear Alicia's story. But traditionally, where genetics started was single gene. Like if you can look at a patient or a family and say, oh, you have these characteristics, then we would go and do testing after clinically observing. So the analogy I use with the families is like recognizing, oh, here you have a chocolate chip cookie, it has cranberries. Okay, which recipe makes this? So you go back and you test, you go find that recipe and you make it, and you're like, oh, okay, this is the recipe that made you, and we have confirmed the diagnosis. But once you have that recipe, and we have like 20,000 genes, so once we have defined this gene is involved in this condition, what has changed now is that genetic testing is available much more, not just for one gene, but across many genes. And we have testing that's called whole genome analysis, where you can test all 20,000. And what we have recognized is when you start doing whole genome analysis first, what that initial recognition of that condition, oh, it only presents as chocolate chips with cranberries. Well, guess what? It also makes chocolate chips with white chocolate. It also makes chocolate chips with pecans.
I'm hungry. I'm getting hungry here.
I use a lot of analogies. I want the audience to recognize
your analogy.
It's because I want families to understand the variability in genetic conditions and how genetic testing has changed, and that we now do a genetic test approach because conditions can be so variable. And the genetic counselors in the health system, we are integrating with every single specialty, from the cancer center, cardiology, general genetics, internal medicine, neurology.
Pulmonary, don't forget pulmonary. Come on now, give it up here.
Pulmonary, to really see how we can bring genetic testing at the point of care.
Yes.
So that you're not depending on the classic presentation of a condition, but you're presenting that information to the patient saying, your symptoms can overlap with many. Here's some testing we can do, and then refer you to specialists who can help interpret this result.
Yeah, I think that's so spot on, because the test can make such a difference in early diagnosis and then treatment. So much we have to link that if we have the right gene, we can develop the right therapy and get the patients to the right treatment. Alicia, your story helps show why these centers exist and why they are so important. Alicia was diagnosed at age 7 with Hunter-McDonald syndrome. It's a rare disorder that causes a skeletal, joint, connective tissue, and craniofacial abnormalities. Her now adult cardiology team recommended a genetic sequencing that wasn't available when she was a child. This field has moved a long way. It turns out Alicia doesn't have Hunter-McDonald syndrome. What she has is TRAF, TRAF7, only defined as a genetic condition in 2019. So rare, it didn't even have a name when she was a child. To explain the testing process, here's one of Alicia's doctors, Dr. Brian Munchmore, a clinical geneticist who specializes in the diagnosis and management of rare diseases.
I get back results from the testing company, and like all things in medicine, trust but verify. So the very first thing I do is verify that it in fact is a disease-causing change. That's usually pretty easy because the companies are quite good, but I always double check and say, yes, there are clear signs that this would be a disruption to the gene itself. The next question is does it fit? Because you can have a change in a gene, but does it fit what the person actually presents to you, the person actually in front of you? In Alicia's case, yes, it fit very well. And then the third and most important part is then you go deep diving, you dig. And you dig to see very specifically, okay, we know about TRAF7, but what about her very specific change? What is known about that? That can be difficult when there are only 5 or 10 people in the world with the same change, but it's amazing how much literature is actually out there. And when you do a deep dive, sometimes you can make very, very poignant medical decisions, and really it's the true precision medicine at that level. There's been a lot of talk about precision medicine for over the last 30 years. This is an example of precision medicine in action, where not only are we ending a diagnostic odyssey for somebody, we're giving them very specifically what is going on, but more importantly, here are your risks that nobody else in the world for the most part have.
You know, that's a really important story, and I think what's really important about it is the ability to get to the right diagnosis. Alicia, when you learned your diagnosis is wrong, what did that moment feel like?
Oh, goodness. Well, when I was diagnosed when I was 7, I just kind of accepted it, and I just grew up knowing that this is something that I had. And so I spent my whole life believing I had this certain thing, and it just very specific to mostly like my family. And when I was re-diagnosed with TRAF7, it was definitely life-changing. I think I'm still trying to get my head around it half the time, because so much of my perspective has been kind of flipped on its head.
Yeah, it really did. And your life has taken a lot of what I refer to as medical detours, to the extent we'd almost say you've had, well, we would say, you've had a lot of health or medical trauma along that journey. Before finding out your results, did you ever feel like Hunter-McDonald syndrome didn't fit or didn't explain everything?
Well, to be honest, it was so rare. The Hunter-McDonald syndrome, it's something that me, my mom, and my late uncle had. So we were the only known family in the United States with it. So everything that it described, it seemed to fit perfectly. I still think that maybe the Hunter-McDonald syndrome is another name for TRAF7, just without the advanced testing.
Yeah. You know, you get this genetic information, you try to fit it into how we've made diagnoses in the past, which were often clinical. That is, we would take a lot of symptoms, we try to put them together and say, okay, that's what this disease is, we're just going to call it. But there's all this variability mixed in that. And so then you realize, well, actually, the genes are going to present differently when they're aligned differently. And so, yeah, they're probably not all the same disease. So TRAF7 alters pathways affecting heart tissue, hearing function, and musculoskeletal development. Alicia has that pattern of symptoms in her family. To explain, here's Alicia's genetic counselor, Farah Amuri.
So think of our genetic information as a library that includes, different books, and the books are, the chromosomes for our body, which hold the genetic material. And so there's different ways to look at the library or our genetic makeup. We can either look more broadly by looking to see if there are any missing or extra books in the library. which is a more broad test, it wouldn't really look more comprehensively. And then there are other types of genetic tests that either focus on specific chapters or specific words within these books that we can analyze. With exome sequencing, we're looking at those chapters and checking the codes, the genetic spelling of the genetic code. And that's a testing that was done for Alicia to check the spelling of her genetic information and try to identify if she was born with a genetic change that would explain why she has those medical concerns, the skeletal dysplasia, her developmental delays, and some of the heart problems that she was having. And also explain the family history, because there's extensive family history of the same condition. So her mom, her maternal grandmother, and her maternal uncle were all affected with this. And as part of the testing, I did offer her mom to be included in the exome sequencing. And we did find that this was a maternally inherited genetic change, that both Alicia and her mother have the TRAF7 related neurodevelopmental disorder.
That's an amazing story, but I mean, because of the clinic I work in, I see that happen a lot. Now, Shobana, when a gene is newly characterized like Alicia's, how do you communicate the uncertainty or lack of knowledge without losing a little bit of that patient's trust? Because you had to tell her, no, you think isn't entirely right, but this TRAF7 thing, that's probably more spot on.
No, it's being on the patient with Alicia on this journey, right? So one of the key things, Farah and my team of genetic counselors that we place a huge emphasis on, even because we know the potential results that come out. So we counsel patients ahead before we do the testing,
right,
that this may uncover findings that have not been well characterized. So it's about earning the trust before the testing. And that's such a huge, important part of informed consent in genetic testing that can help inform how well patients can react. If you're prepared, then it comes from a place of honesty and transparency. So they're not blindsided by, so it's just about making sure the family and the patient is prepared. Like, we're doing this testing because it wasn't available back then.
Right.
And yes, your diagnosis is part of your identity almost if you've lived as a child and an adult, but we're going to find some information and walk with you through this process. Our whole team is.
Well, and then trying to develop therapies is so much better when you have an actual gene defect and you can say, okay, this is the correct thing. It's like cystic fibrosis. There are several different drugs for CF now, but it's genetically defined. Which drug do you want to use? Unfortunately, a lot of the defects fall into a couple of broad categories of drugs, but some defects don't. We still have to go continue to do
Can I
work.
add one more food analogy?
Please
that
do.
helps?
Oh my God, is what something else they're going to want, like chocolate and cranberry? I don't like dark chocolate,
one of
especially
the
dark
ways, because how do you do informed consent? How do you prepare a family for testing? So for those hearing this, think of it this way. Before we do testing, I always say, we're going to test recipes. But I can give the same recipe to two individuals in the family, and they will make it differently. And that's what variability is.
Yeah.
And when you
That's pretty good. I'm stealing it.
So that helps them. They're like, it clicks.
Yeah.
Because it's relatable.
Yes.
And counseling is about making genetic information relatable and meaningful.
Oh, that's great. That's a really good example. Okay, we spoke to one of Alicia's genetic counselors, Juliana Askren, on how she helps people process their results.
There's not a correct way to react to this information. So whether that's excitement that maybe now there's a little bit more resources, although it is still a very rare condition, and now knowing that there's other people to connect with, or if that's grief over kind of grieving that diagnosis that you had before and being able to tell that story there. Both are very valid and go hand in hand. And I also like to tell patients that when they test positive, it's not a change in their body, it's something that they've lived this long with and their body's always known about from the start. Now it's a change in our knowledge of their body, and we can take action and see what other symptoms are associated and be on the lookout for those. And also just have that information and have a better understanding of what's going on with the body. And it's not a change in who they are. They've always been someone living with TRAF7 neurodevelopmental condition, but now we know about it.
All right, Dr. Lepichon, How does a NORD designation impact families like Alicia looking for answers? Does it give them quicker access to experts, do you think?
Yeah, so actually, I think it does something much more fundamental than that, and that is it addresses directly this diagnostic odyssey that you have been sort of highlighting with Alicia's story since the beginning of this podcast this morning. And it's quite remarkable if you think about it, that, Alicia had to go all these years before she got the correct diagnosis. I will never forget a family who had a adult child with autistic-like symptoms, and I arranged for them to be sequenced at Children's Mercy, and we actually were able to get a very rare genetic diagnosis, which, just like Alicia had been described maybe a year or two before, was extraordinarily rare. But when I delivered that news to the mom, she dissolved into tears. And she said, "This is the first time in my entire life that I know I didn't do something wrong during the pregnancy." And that is meaningful. And so, in that sense, this ability to go from, what Shobhana was talking earlier about, going from this approach where we would try to look at the symptoms and put the answer together, to the approach where now we can start with genetic testing, either with genomes or exomes, and provide an answer to the family is a huge difference. And then it can also do something else, which several people have talked about during the podcast this morning, is that it can put you on the way to better treatments. And so, an example of that is I have one of my kiddos who has a severe epilepsy. And we found out that this kiddo has a calcium channel variant. And so we postulated, well, maybe we should use a calcium channel blocker to treat the child's epilepsy. But we weren't very willing to try that just willy-nilly in the child. So we grew the child's cells using their white blood cells. We differentiated them back into brain cells in the lab, and we tried various calcium channel blocker. And guess what? Nifedipine, which is a blood pressure medication, worked really well to treat that child's seizure. So who would have known? So what being a part of NORD does is it puts you in a place, in a center like the KUMC, like Children's Mercy, where there is access to that type of expertise, sequencing, the ability to not only get those results and avoid this very long diagnostic odyssey, but also to then translate that in something meaningful, as Shobhana was talking about, as Farah was talking about, for the family, and help the family understand. And I'm struck by something, Steve, that was this really kind of blew me away, because Alicia had this incredible insight, which was to say, I'm not sure this disorder, this genetic finding that I have wasn't a part of this disorder I was diagnosed with before. And in doing this, she's actually put her finger on what Shobhana has been talking about, which is phenotypic heterogeneity. And so it's quite remarkable that through the work that Alicia has done with KUMC and with the group of remarkable therapists and physicians and genetic counselors that she has there, she was able to come to that insight, which is actually a fairly advanced concept from a medical point of view. And that was done because she was in a center that had this kind of expertise. And that is what being a part of NORD really brings to patients like Alicia and like many of these other patients, which, as you highlighted earlier, that's, although these diseases are extraordinarily rare in and of themselves, it's 1 in 10. We probably all know someone with a very rare disease.
Yeah, you bet. And again, I'm complete fandom here because of the world I work in, and not because I have a Red Christmas vest on, but because I have this overwhelming belief in the impact of science in changing the diseases, because I've watched it happen in my career in medicine. And that could not have happened unless people worked on this and went into the lab, worked on the genetic defects, figured out figured out what therapies could do, and then translated them into the bedside. That story is the story of success, and it happens when people get to come together with really clear understanding on the basis of a disease, especially on the basis of these genetic diseases. Alicia, you're a filmmaker. Now that's awesome. How do you use that passion of storytelling to process your experience? And by the way, I love the black hat. It works great. I'm going to go get one.
Oh, well, I've always considered myself a creative person, and because I do have a very unique life experience, I do try to put that into my art in several different ways, whether it's filmmaking, cosplay, just sewing in general, just so many different outlets, just with art. I think there's a way of just putting myself out there in ways where I hope people can see that there is more than just a disability, but it's also a big part of who I am.
Yeah, that's awesome. Now, Shabana, what is the scientific advantage to redoing genome, why can't I say that this morning, genome sequences years later as classifications and knowledge evolve?
Yeah, because new gene discoveries. So let's say you read the book that makes you human, 20,000 genes. So genome analysis is not about repeating the blood test, repeating a blood draw. We have all of the recipes that make you unique. But what we get better over time is reading those recipes. I'm sorry, I just have to end with that.
You and Alicia are going into the kitchen and making a film about genetics. I'm just saying that's what's coming.
It just, I can't stop. That is the way I talk.
I think she's there. Listen,
yeah,
she's just
so Alicia knows why, when you come to a genetic counseling session, it's all about.
It's all about food. Gotcha.
Yeah, like it's to make sure that they walk with a good understanding of this. So we get better at decoding. We get better at interpreting. As Dr. Muchmore said, we do a deep dive into that data. So what I would say is if you've had any type of genetic testing, even in the past 12 to 18 months, contact genetics, because that is how fast the technology and the interpretation evolves. So if you've had genome analysis a year, 18 months ago, and you want to reread it, you're just repeating, not repeating the interpretation, there's about an incremental diagnostic yield of about 10%.
Yeah.
Because that's how rapid.
It's so fast.
Yeah, so it's just basically if I give you a recipe and I ask you to make it over and over again, you get better at making it.
Yeah, and you can change it a little bit.
Yeah.
You can be better. All right, we're here to answer your questions. Send them using the links on your screen, YouTube, Facebook, or email the Medical News Network. We're going to check in with Doc Hawk. I love your graphic, Hawkeye, because the wings move. All right, we want to touch again on the CDC Vaccine Advisory Panel, which voted to drop the decades-old universal hepatitis B birth dose recommendation for all newborns. Okay, come on, we're politicizing healthcare, people. Stop it. The change is being rejected by health departments and doctors.
Yeah.
Hawk?
I think that's the important thing. This is a decades-old universal vaccination strategy to protect babies, but also protect them as they get adults, because hepatitis B, we know, is a significant cause of liver cancer as well. Nonetheless, unfortunately, this group did vote to rescind that universal hepatitis B vaccination dose within 24 hours of birth. This is going to have lasting effects. This, just as you said, physicians, medical groups, people who know and understand the actual science are continuing to promote the universal hepatitis B vaccine dose. We could have a show on this for hours about just the misinformation, the out of context information, and specifically the outright lies that were presented during that meeting. In fact, there was an organization called the Evidence Collective that tried to listen to the meeting just as I did, and they found at least 60 misinformation or lies that they stopped at 60, to which now they have debunked those lies. It is on their website, evicollective.org. Everybody can see this, but the news is out there. Everybody knows and understands that. It is very unfortunate. There are continuing to be barriers towards extremely safe and protective measures for the American public, specifically with vaccinations. And, you know, vaccinations are clearly safe. They are clearly effective. And I just would go back to also say, you know, we always talk about the insurance companies and wanting to save money and all that. You know, the insurance companies are still going to cover these vaccines from what we know. And why is that? Because on one hand, we say insurance companies just want to save money. Well, they know and understand what helps save them money. And that intervention is vaccination, safe and effective vaccination. So it is very unfortunate. But again, just as you said, Steve, the major medical societies and physicians are continuing to back the safety and efficacy of the universal hepatitis B vaccination right within 24 hours after birth. And one of the things that was also talked about was that countries don't have it. Other countries don't have this universal vaccination. That's actually one of the falsehoods that are described in this. Out of 194 World Health Organization members, 115 of those countries do have universal vaccination straight after birth. There was a lot of comparison to Denmark. I think we have to understand, though, that unfortunately, you know, Denmark is 6 million or so people, 16,000 square miles. United States is 340 million people and over 3.5 million square miles. Not to mention the fact that there was talk of, you know, testing the baby for antibodies after a first dose as well of the vaccine, you know, after that 2-month dose. Well, then that's just giving the baby another stick. In addition, ACIP really doesn't make recommendations on diagnostics and things of that nature. It's really only recommendations. And again, recommendations, not policy, not mandates, but recommendations for the public as a whole. So we have to understand that. Also, you know, the U.S. is not like Denmark in the fact that a lot of these other countries also have great access to medical care, great access to prenatal care. The United States does not have that. And also no universal health care system as well. So there are a lot of pitfalls to that strategy as well. But what we need to say is that the vaccines that there have been increased barriers to continue to be safe and effective and have proven this over time.
You know, the concern, Hawk, and I couldn't agree with you more, by the way, which is probably, we already knew that, the concern among public health experts.
It's the science, yes.
Oh, science, that's right.
The science.
Science. It's like magic, only it's real.
Yeah.
Public health experts is that the new recommendation will make guidance around these vaccines more confusing, making it harder for clinicians to implement because patients don't understand it about. So what would you tell parents about who are welcoming a new baby? What evidence is there to support this? And give us your thoughts. And I'm going to turn to Dr. Lepichon, a pediatric neurologist, because I bet he has some ideas around that one.
That'd be great.
You're first.
You want me first?
Yeah,
you know, again, I think he would be a great voice for this because it is pediatrics. Again, I fully support vaccinations. You know, vaccines are not brought to the market in the United States without good safety and efficacy testing. And even after that, there are safety nets to look for safety measures and issues. The hepatitis B vaccine dose right after birth has been given for decades. It continues to be and show that it is very safe and very effective at reducing or almost eliminating the fact that that baby may get hepatitis B, you know, sometime after birth. So I would continue to support that dose straight after birth, but also all the other vaccines that there is increasing barriers to accessing.
Dr. Lepichon.
Yeah, Steve, thank you. You know, I'm a child neurologist, and as a child neurologist, I tend to see a lot of patients with fairly devastating neurological disorders. And the importance of vaccination in these patients cannot be overstated. You know, this new direction that is being taken by the current administration is a devastating blow, in my opinion, to what it is potentially going to do to us, and specifically to my patient population. Most of the diseases that they're being protected from, you know, if they get exposed to those diseases, can result in a catastrophic decompensation. For example, a child with a mitochondrial disease, if they get the flu, they're at risk of a much worsening in their disease. So, you know, you get the flu, you're going to be sick, you're going to be in bed for a week. That child is going to be in the pediatric intensive care unit and may not recover ever. If they're actually at risk of dying. And so we see this consistently. And, you know, these vaccinations protect both us as individuals, but also those people around us who are more fragile. And, you know, to deprive those people around us who are more fragile under the guise of some pseudoscience is unconscionable. And, you know, I don't have enough words to say how devastated I am by what is going on right now at the level of the CDC.
Yeah, the vaccine amateur hour. That's just great. But yeah, I'm right there with you. All right, we know many of you have questions. Let's head to Studio B with Alexis.
Great questions coming in, so I'm going to get right to Jeremy's. Jeremy wants to know, how common is it that rare diseases originate in the genetics of the patient?
Oh, that's a great question, Shabana.
Yeah, so rare diseases, we would say, you know, in the genetics, let me redefine. We can find the genetic reason about 30 to 50% of the time. So there is a genetic, we always say with any condition, it's a combination of genes and environment. So to answer Jeremy completely, it is the finding the genetic component of it. We can find that 50% of the time, but there's still the component of how it is expressed. How is it made? And we still are trying to define how within a family, cystic fibrosis, twins, anything, why there is variable expression. So I hope, Jeremy, that helps you understand that genetics is to help find out the why a person has a unique set of medical conditions, and to drive that and use that information to drive treatment. So even if we don't find an answer, we have a pretty good chance to find it and use that information.
And I think, you know, Dr. Lipichon, you gave a great example of that earlier today, but man, it also drives research questions, because once you understand what the genetic cause is, then you can start thinking, okay, how are those genes linked? What does it do to the cell to make things not work correctly? And then what can we do to help change that? So back to you, Alexis.
We have a question for Alicia from Toby, but first, Dr. Stites and Shobana and Dr. Lipichon, I got to tell you how modest Alicia is being. She is so creative. Photojournalist Cliff and I spent the afternoon with her at her apartment. She makes those cosplay costumes that you see her in, and she wins awards. She's so creative, in addition to being a filmmaker. Yeah.
Yeah, that's what a great story.
And we got to meet her mom, and she's just such a fascinating person. And we're going to do a future episode with Alicia, so people will get to know her even better. But Toby wants to know, Alicia, did this change your treatment, this new diagnosis of TRAF7?
I don't think my treatment has changed at all. I'm still the same person I've always been. I still have the same health complications I've always had. I don't think any of that has changed. I do have the opportunity to learn more, because I believe there is a bit more information about TRAF7 than there ever was the Hunter-McDonald syndrome. So learning more is probably the best way I can move forward, just because I don't think treatment-wise I've really changed, at least not yet.
One thing you shared with us when we were interviewing you was that you were able to join a support group, but it's all parents of kids that have the same thing you have?
Yeah, that was definitely a curveball because with the Hunter-McDonald syndrome, I kind of grew up believing I was kind of the youngest known person with this disorder. And when I was diagnosed with TRAF7, I was pointed to a Facebook group, and there was most of the group is parents with children, ages like around 2 or 3 years old with TRAF7, and so suddenly I'm seeing, you know, little children with a lot of the same skeletal differences that I had as a child, and suddenly I'm not that young anymore.
Yeah, that's a weird feeling, right? Adrian has a question. She wants to know, what about commercial testing for genome sequencing? Would that be available? Can you request it going in to your doctor's office before a physical, say?
Great question. I can say that within the health system, the short answer is yes, there are many commercial laboratories that offer genome sequencing. There are variations in the quality. Anybody can do sequencing, anybody can print that report, but it's the interpretation of that. It's decoding it, as Dr. Muchmore said, trust but verify. You get this data, but you want to be able to do a deep dive into it. So that's where the differences lie in even the expertise of the laboratories. Second part of the question was, can I go and just get the testing? The short answer is yes, anybody can order testing, really not just genetic testing, but really any testing. But you want to make sure that you are aligning with a provider who knows how to interpret and use that test in your care. So whether you're seeing your neurologist, pulmonologist, there are many different levels of testing. So ask your provider, I'm interested in this testing, and given my symptoms, do you think this is something I can go through you, or do you think I should be referred to a specialist? And the types of specialists, I mean, genetics, that's what we do, but we are partnering with all of our specialties here in the health system. So we are trying to integrate genetic testing both at the primary care level and across all the specialties. So the short answer is yes, anybody at this time, but I would also add a layer to that question to say, who do you think would be the most appropriate that I should see given my symptoms?
We have one more comment. This is from Cheryl White. She wants us to share, thank you for your ongoing presentation of scientific information.
Wow.
You bet. This has been a great discussion. I'm always grateful for our guests for being here today, but I want to tell you what a great team of people here this morning. I want to hear final thoughts before we go. Alicia.
Yes.
Final thought for today.
Final thoughts.
Or last bit of wisdom.
Final thoughts. I'm just glad to be here, and I just want more people to be aware of genetics, genetic testing, rare diseases. Just being aware is very important.
It is. That's a great point. Thank you, and thanks for being on the program. And thank you for sharing your story and your artwork. Dr. Lepin-Chong, final thoughts today.
You know, I have to say that for me, the highlight of today's podcast has been to get to know Alicia, and I am honored to have been on the same podcast as she was. And Alicia, as a young and talented artist, you were just describing, so all of a sudden you find yourself being, you know, the oldest or one of the older people with this disorder. Remember, you have now become a beacon of hope for all of those parents. They're looking at you and they're thinking, my child can can grow up and be like Alicia. And that is really important. So thank you for being here. Thank you for being that witness and, you know, for carrying that forward.
All right, thank you, sir. We also wanted to hear from Alicia's team one last time. Here's why they think the NORD designation is so important to their work.
My hope for Alicia and anyone who gets a firm diagnosis is that they feel empowered with this knowledge to move forward and also connect with multiple resources and other individuals who have the same conditions so that we can work towards more research and more treatment options and also a better understanding of the conditions themselves.
The NORD designation, I think, is very useful as a beacon saying, we are here and we are capable of taking care of your rare disease patients. And it's also useful just for basically communication, for communicating with other people and saying, we're here, we know what we're doing, let's talk and share information.
Yeah, I think when patients are aware that our health system and medical center have this designation, they feel more comfortable reaching out to us and regarding their rare diseases, because they know that we have capacity, we have the providers, we have the specialty clinics that are able to understand their diagnoses, especially their rare ones, and care for them as best as we can.
All right, Shobhana, final thought.
Just thank you, Alicia. When you share your story, it leads the way for others. And I think that's way powerful than anything that I can say about all the care and providers that we have here. I think your story is just going to lead others to getting the health care and the early diagnosis.
And the help they need. All right, before we go today, I want to come back to Alexis Delcid to share another story on the importance of genetic testing. She'll be talking about it tomorrow on All Things Heart.
Back-to-back episodes, Dr. Stites. It's really serendipity that we're talking about this again tomorrow. Tomorrow's program is another example in finding answers. Manuel Romo had some terrible losses when he was growing up. His twin brother, his sister, his mom, lost them all to a genetic condition no one knew they had. Years later, a new diagnosis and life-saving heart surgery and genetic testing revealed the true cause and gave him a future. That's tomorrow on All Things Heart.
I want to say thanks again to all of our guests and to all of our audience out there. You know, I'm always impressed by people and our patients who are here. Their stories are always compelling. But what you really heard today is Alicia's story and the story of science. Science told in an open, honest, real fashion, not with politics, but with patients and with the people who take care of them. That's how we can all live long and prosper. Thanks, Joe. Remember, faith, hope, and science, you know what? It's a combination you can believe in. We'll talk to you soon.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.